All right. Well, it seems like it's maybe slowing down a little bit, so we will just go ahead and get started. Hello, everyone, and welcome to the Great Plains Quinn Friday Focus for Health. This series is focused on patient and resident safety to reduce C. diff and hospitalizations associated with it. This Friday Focus for Health is hosted by the Great Plains Quinn Innovation Network, the Centers for Medicare and Medicaid Services, Quality Innovation Network, Quality Improvement Organization for North and South Dakota. My name is Stephanie Meduna. I'm a registered nurse and a quality improvement advisor for the Great Plains Quinn. I am here today along with my team, Lori and Tammy. We want to thank you all for joining today. Today's webinar will be recorded and will be posted within 1 to 2 business days on our website at greatplainsquinn.org under Friday Focus for Health link. If you have questions, please add them to the chat. We will add a resource handout that you can access as well. This resource handout includes all the resources shared during today's session and will be added to as the 4-week sessions occur. This week's focus will be on risk, and next week's will be on the spread of C. diff. Week 2 for this segment of the Friday Focus for Health regarding Clostridium difficile infection, I'm going to refer to it as CDI. We will discuss the risk and how to detect C. diff. C. diff is a bacterium that causes an infection in the large intestine, also known as the colon. The illness usually occurs after the use of antibiotics. People are 7 out of 10 times more likely to get a C. diff infection while taking an antibiotic or during the month after. It most commonly affects older adults in hospitals and nursing homes. Extended stays in healthcare setting increases one's risk to get C. diff as well. In the United States, about 200,000 people are infected by C. diff because of being in a healthcare facility. More than 80% of deaths that occur are in people who are 65 years and older. And that is the age group that makes up a large majority of who we have in our nursing homes and hospitals. Some additional risk factors include those with a weakened immune system, such as patients who have HIV or AIDS, cancer, or if they have an organ transplant and are taking the immunosuppressive drugs. Another risk factor is having a previous infection with C. diff or a known exposure to the germ. Antibiotic use and previous exposure to C. diff are the two main risk factors. Antibiotics like fluoroquinolones, cephalosporins, carbapenems, and clindamycin have the highest risk for C. diff. People outside of a care setting can also develop C. diff infections. Some strains of C. diff in the general population may cause serious infection and is more likely to affect younger people. In the United States, about 170,000 cases of C. diff occur outside of facility, and those numbers seem to be rising. Last week, Tammy shared with you the decision tree for the diarrhea management, and that tool will go along, and we'll talk about that after we review the slide. Early detection of C. diff is very important for the patient. Not only can it start treatment sooner, but it also keeps others from getting ill with C. diff. We all know how contagious C. diff can be. C. diff should be considered in any patient with watery diarrhea or abdominal pains following an antibiotic exposure within the previous 3 months, or an exposure to C. diff in the healthcare setting within the past 3 months. So the tool, the decision tree that Tammy had shared last week, has some very important questions on there. One is such as stool softeners, where stool softeners are laxatives given to the patient or the resident prior to having loose stools. So go ahead, stop those for 24 hours and see if the diarrhea persists. If the diarrhea persists, we want to collect a stool sample and send it for testing. If the patient has recently had a positive test, do not send another stool sample for cure. People sometimes have more than one bout with C. diff, so if symptoms subside and return, they should be advised to contact their doctor. So the recurrent rate of CDI, 15 to 20% after having your first episode of C. difficile, 30 to 45% after that first reoccurrence, and then 40 to 60% of people who after 2 or more reoccurrences happen. So it is possible and it is likely that once you have one episode, it could come out again. So here is an example of a process improvement discovery tool for CDI. Great Plains Quinn is currently working on this tool, and it should be available before we are done with this CDI webinars. With this chart audit review, it is completed. You mark yes to the statements that are true. It is very easy to read, total up your numbers, and if there are those boxes that are marked, it may lead to a process improvement opportunity. It helps to identify those gaps that you have and resources you will need to make the change. Okay, so now we're going to talk about the guidance for stool collection. Maybe none of you have had the problem, but it seems like every time you, or the first time you send off that sample for a C. diff test, it seems like you get a call back from the lab saying, we're not accepting this one. So with that, if you're thinking a patient is positive with C. diff, we're going to send that sample. And if they're in a healthcare facility, we need to ensure that they're placed in contact precautions before sending that sample down or when you are thinking CDI with that patient or resident. Here is that guide tool to utilize for stool collections and submissions. When doing testing, if using the Bristol stool form scale, the stools that resemble the pictures in 5 through 7 is the type of stool that should be sent to the lab. So here we will review some do's and don'ts for the collection of stool submissions. Sorry to you if you're eating lunch. I'll go quick over this. Some do's that we have is submit fresh stool samples for CDI testing from patients with suspected CDI greater than 3 unformed stools in 24 hours. Avoid repeat testing. Submit 1 specimen per patient. And once again, we don't want to do that test with the same bout to test for the cure. Retest for CDI only if CDI symptoms continue or recur after 10 days of treatment. Refrigerate, store at 2 to 8 degrees Celsius until the tested stool sample can be sent to the lab. And then collect specimen in a clean, watertight container. And usually it is that specimen container that you can get from the lab that you utilize. Some of the don'ts that we don't want to do. Don't test asymptomatic patients for CDI. Don't perform tests of cure on any patients or post-treatment. Don't conduct repeat testing during the same episode of diarrhea for a confirmed CDI patient. Don't transport the specimen in media that may increase false positive test results. So always speak with your lab so you know which is the correct specimen. And then don't wait to transport the specimen. Transport specimens as soon as possible after collection, if able. If not, that's when you want to go ahead and put it in the fridge till it can be taken to the lab. Some of the common complications of CDI can be dehydration, and that can lead to kidney failure, inflammation of the colon, also known as colitis. There are also some rare complications which still can occur are toxic megacolon, sepsis, and even death. If C. diff is not diagnosed timely, any one of those symptoms could possibly get you admitted to the hospital. So now we're going to talk a little bit about people who have C. diff. We're going to talk about whether or not they are colonized or whether or not they are infectious. Because C. diff is a bacteria that's found in the human gut, the bacteria can be detected in diagnostic tests even though the patient is not showing any symptoms. It is important to distinguish between those that are colonized cases and those that are infectious cases. If someone is colonized, the patient exhibits no clinical symptoms. The patient tests positive for C. diff organism or its toxin, and C. diff colonization is more common than the C. diff infections. A C. diff infection, the patient is exhibiting those clinical signs of the diarrhea. The patient also tests positive for the C. diff organism and or the toxin. Testing of asymptomatics can lead to a higher incident of CDI within your facility. So therefore, you want to make sure you know whether or not you are dealing with a colonization or an infection going on. So how do we do that, or what kind of tests do we utilize? So culture is the most sensitive test that is available out there, but it can take 48 to 96 hours. The antigen detection detects the presence of the C. difficile antigen, and this is a rapid test, is ready in less than an hour. And then that should be combined with toxin testing. Toxin testing identifies the toxin A, toxin B, or both A and B. Those are usually same-day results as well. And then we also have the PCR that we can do to detect toxigenic C. diff in stool. This test is a potential advantage, is ability to determine those strains, for instance, whether they make the toxin and to which toxin type they belong. A more sensitive and more specific approach is with the PCR. So once again, make sure you're checking with your lab in regards to what tests they have available and what you are sending over. In some cases, examination of the colon can also be used to help confirm a diagnosis of C. diff, such as the use of an endoscopy or CT scans. So now we're going to view this video in regards to talking about the diagnosing and how C. diff has become more pronounced within this time.
I think big things are it's becoming increasingly common in patients in the community who haven't.
Whoops. Sorry.
spend time in hospitals. A long time ago, I used to only see it in elderly people who'd spent tons of time in the hospital, gotten tons of antibiotics. Now we're seeing it in young people, people who haven't been in the hospital, women who may just have delivered a baby and gotten one dose of antibiotics around a C-section or something. So the rate of C. diff is increasing. We're also seeing C. diff that's sometimes more resistant to treatment or cure. We're seeing more recurrent cases where people get C. diff over and over and over again, despite being adequately treated and recovering. As soon as they stop the treatment, a week or two later, they're coming in with a relapse again. So we're seeing more and more of that as well. One of the big things is use of antibiotics. Another is, we know that one of the biggest risk factors for C. diff is antibiotic use. Antibiotics disrupt the normal, good, beneficial bacteria flora that prevent C. diff. And so people use antibiotics a lot, kind of as a population. We've made efforts to decrease use of antibiotics and increase, antibiotic stewardship and doing the right thing, but we still see that there's a lot of antibiotics given. Another big reason is probably the aging population. More a risk for C. diff is age over 65. Your risk for hospital-acquired C. diff increases by 2% for every year you are over age 18. So the older you are, the higher your chance of getting a hospital-acquired C. diff infection. And we're seeing many more people over 65, so we're going to be seeing much, much more C. diff. For symptomatic C. difficile infection, you're seeing diarrhea, primarily diarrhea. It's often described by the patients as explosive. They become incontinent with it. Sometimes it's watery, profuse diarrhea. Some patients have abdominal pain with it, or they'll have more sort of a mucoid-looking diarrhea. Some will have bloody diarrhea. Some can get very, very sick and end up with fevers, significant abdominal pain. Actually, it can, in a percentage of people, land them in intensive care units where they're really in sepsis from it. And thankfully, that's a small fraction of the people who get C. diff, but the rates of death in that group are very high. Something like Prilosec, one of those kind of antacid or acid suppressing medications. There's evidence that use of those medicines can increase people's risk of developing C. diff. So if people are on those medications and they don't have a real good reason to be on those medications, I'll usually have them stop them. Obviously, if they're on it for some important reason, they can't stop them. The other kind of thing to think about that might modulate your risk of C. diff would be use of probiotics or beneficial bacteria that would kind of go in and potentially help prevent C. diff. I think there's fairly good data in the form of a recently published systematic review meta-analysis that shows that you may be able to prevent C. diff infection from occurring initially if you give a probiotic at the same time as you're giving an antibiotic and kind of for a week or two afterwards. And you can almost pick any probiotic out there, but they showed that you can reduce the risk pretty significantly. You have to treat about 29 patients with a probiotic to prevent one C. diff infection, but that it may be worth it, maybe targeting higher risk populations with that prophylaxis.
Oops, let me stop this. Here we go. All right, so that was a good overview in regards to C. diff infections and how they come about. With leaving in action, I want to reference our GP Quinn Quality Improvement Project Guide and Tools. We always talk about starting small whenever we start a quality improvement project. If you are a larger facility, you may want to look at starting on one wing or one floor to start in small options. After you have completed your chart audits, you start to look at those gaps and outliers that were identified. Things you could look at are if the patient had any stool softeners in the past 24 hours. Is this a repeat CDI diagnosis for the patient? That could lead you to the question of if they are colonized or not. Was the stool sample that was sent appropriate, or did another sample have to be recollected? Were there antibiotics used in the last 60 days? And of course, the overall goal is to prevent patients from having to go to the hospital or having an extended hospital stay. In last week's numbers, Tammy showed our numbers of hospitalized patients with CDI and how they have increased over the last years. Now it is time to look at those numbers and identify your plan. Your plan or interventions may be to identify if residents are being diagnosed timely. If they are not, could that lead to an hospitalization? Was the patient on an antibiotic? In session 4, we will talk more about antibiotic stewardship. So once your interventions are complete and you have seen your improvement in your project, that is when you want to spread it out facility-wide. So I have on there to set your goal and, to start out small, reduce hospitals due to Clostridium difficile infections by 10% from your baseline by July 23rd. With starting that quality improvement project, I'm sure in no time you would have your goal obtained. All right, now we will move into our office hours portion. This is the time where you can ask questions, and GP Quinn advisors are here to help with any sort of questions that need to be answered or things coming up. Regardless if you're a clinic, a home health, or hospital, nursing homes, we all have these same situations, and we would like you to let us know about your experiences with any CDI admissions or readmissions or outbreaks that you've had within your facility. Okay, I'm not really seeing anything here. I do have a poll that I am going to go ahead and launch. It should be coming up in the middle of your screen. And it is, how many cases of CDI do you have per year in your facility? And then it's 1 to 5 cases, 6 to 10 cases, 11 to 15 cases, or more than 15 cases per year. Okay, looks like we have some responses coming in. There are 8 responses at this time. Looks like 100% of them are saying 1 to 5 cases. Okay. Then I have another poll here, kind of in regards to the same thing, just wondering about hospitalizations. Okay, so this one says, how many of your patients or residents end up in the hospital due to a CDI? None, 1 to 5, 6 to 10, or 11 plus. You could go ahead and answer that. I would appreciate it. Okay, we only have 3 responses at this time. Oh, here we go. All right, it's going back and forth. So about 75% are saying none of their patients or residents are hospitalized or have an extended stay, and 1 to 5 is 25% say they have had 1 to 5 residents or patients admitted to the hospital. All right. So with that being said, we will continue with our office hours portion. If any of you have questions that you would like to go ahead and discuss, come off chat and let us know what you're thinking about today, or put a comment in chat.
Hi, I was wondering, do any of the facilities have protocols of when they start antibiotics that they implement a probiotic?
Okay, did everyone hear the question? Wondering if the facilities out there have a protocol to start a probiotic when antibiotics are started. Marie has no outbreak, but I do have one resident who is colonized and is on a prophylactic antibiotic for it. Recently, he was on another antibiotic and his prophylactic was put on hold. The restart was missed by 1 day and he became an active C. diff case. Lisa answers back that they do not. Jessica has, we do not, but after this, I'm going to put one in place. All right, and Tamara says, I agree. Okay, and Marie comes back and she says, my question is if someone is on an antibiotic for prophylactic for C. diff and start on another antibiotic for a different infection, my question is, should we put the prophylactic antibiotic on hold? So with that question, Marie, I would say yes, but the thing that you're going to want to do is check with your physician who is ordering that second antibiotic and ask them if they would like to discontinue the prophylactic while they are taking the other antibiotic for whatever recent infection they have. And then Tammy has it suggested to take the probiotic 2 to 6 hours after the antibiotic dose throughout the course of the antibiotic treatment and continue with the probiotic 7 to 10 days after ending the antibiotic regimen. It is also helpful to take probiotics before beginning antibiotic therapy if possible. Okay, let's see here. And Tammy does have the link in there as well. Lisa has, I think there is differing opinions about probiotics. Have seen physicians opposed to them. Yep, you are correct, Lisa. It does depend on the physician. So, starting a protocol, you always want to speak with your physicians in regards to that, whether or not it is something that they want started on their patients or residents, or if they do not. So there is definitely differing opinions on that. Okay, any other comments coming in?
I don't see any, Stephanie. I was trying to find NIH study or the meta-analysis.
Okay.
So the most recent one I found was 2013. I think there is a more recent one. I just need to find that and we can sure have that. So that'll help you with some backing to have those research studies.
Yes, thank you for looking for that and putting it into chat. We will go ahead and give Tammy a couple of seconds, but in the meantime, I am just going to go ahead and say that I want to thank you very much for attending, and please complete the webinar evaluation so we can continue to work to make our time together valuable. We really appreciate your feedback. Attendees will be dropped off at the evaluation conclusion of this call, or if it's easier for you, please scan the QR code and click the link within the chat to complete the form. as always, we really value your feedback on these weekly Friday Focus for Health sessions, and also any ideas that you may have for future topics. Here's the QR code to use with your camera on a smartphone, or the link will be placed into chat. We would love for you to open this up and be ready to provide us feedback at the end. And I'll just go back to Tammy real quick. Did you find the more?
I did, from 2018. So I just stuck that in chat. The one thing I would suggest is, since this is a smaller group in the nursing home and community listservs are much larger, that I think there probably are protocols out there, not just the one that I found quickly and posted. So the listserv, and if you don't want to ask that question yourself, we can post that for you. But sometimes it's easier if you post it and then those responses come right back to you.
All right. Well, that sounds great. Tammy, thank you for adding that into chat. Once again, I want to be conscious of your time. So we are right at the top of the hour. I want to thank you again for joining us, and have a great St. Patrick's Day and weekend.
Please do the eval.
Please do the eval.
One thing, just a minute. Jerry Sorensen, our pharmacist at Great Plains Quinn, she wrote in chat, there's a lot of literature that is controversial. It's challenging to compare studies with all the variability. Providers who recommend them believe that possible benefits outweigh risks. So
Yeah.
I think that that's certainly.
Yeah.
All right. Perfect. Thank you. Thank you, Lori, for seeing that. I wasn't in my chat at the time, so thanks for bringing that up. All right. With that being said, once again, happy St. Patrick's Day and have a great weekend.